Yep, I'll just start sharing my screen and we'll get started.
Yep, we're rolling.
Okay. All right. Is that visible for everyone?
Yeah.
Perfect. Okay, so we're moving on to week 5, and week 5 means another week of anatomy. So we're moving on from upper limb and going on to lower limb. So away from the arms and down to the legs, which is going to be very similar to upper limb in that there's a lot of symmetry between the structures in your arms and your legs. So when you have a good understanding of your arms, it helps with really understanding the muscles and the bones and all the structures in the leg. But I understand that it's been a pretty rough journey so far. So we're going to try and make it a little bit simpler for you in terms of the actual content itself. So I was going through sort of the content, and I realized that a lot of you probably are not really that well versed with upper limb. I was having a look on Facebook and I saw this post and I thought, there's no way that we're going to just bombard you with more and more content without first giving you a good sort of structure to build off of, right? So I understand that upper limb is very hard. Even when I was in semester 2 of anatomy, I barely understood upper limb until the holidays when I had time to really consolidate everything. So my tip for all of you is that it takes time, and upper limb will sort of make more sense as you learn more and more about lower limb as well, because very similar structures. And I think you'll have a lot more time to spend on it and learn about it on the holidays, when you can really like sort of not get bombarded with more new content and just focus on learning what you've already been taught in your previous lectures. With that being said though, let's sort of just talk about the basic concepts from our upper limb topic and bring them into our lower limb content as well. So some things you got to keep in mind are that first of all, your bones are going to be the scaffold of your human body. They're going to be the base structure which everything is built off of, right? So just keep that in mind, that the deepest structure usually in your upper limb and lower limb is going to be your bones, and they form joints where they articulate at. The ligaments are these structures that hold the bones together, right? So ligaments hold bones together and they provide them stability, and they are useful for the joints where there's very, very unstable movements. For example, the shoulder, we saw that, but also down in the lower limbs, we're going to see it around the pelvis, around the hip joint, and further below as well. Bursae, again, they're not going to be very useful in lower limb, but again, just keep them in mind. They reduce friction between sliding surfaces. Muscles, they contract and they produce movements at joints. So the muscle over here, for example, I don't know if you can see my cursor, but there it is. Okay, so the muscles, they contract at the joints and produce movements at the joints by bringing the bones either closer together or moving them further apart, right? And tendons are the structures that actually anchor the muscles to the bone, right? So tendons hold muscle to bone, ligaments hold bone to bone. And finally, nerves are those structures which actually stimulate and control muscle contraction. And they also have a sensory component as well. So you just got to keep in mind that there's both a motor function for nerves as well as a sensory function as well. And just to help you orientate yourself a little bit more, here's a little diagram that shows all of those in context. The yellow thing there is a nerve, which is really badly sort of drawn in there. But the main thing is tendons and ligaments, right? Tendons hold muscle to bone, ligaments hold bone to bone. That's a really important thing to keep in mind, because when they use those words a lot, it gets very confusing. Just keep in mind that those structures have that function. The next thing I think which is very, very confusing with upper limb, is all the fascia, the spaces. What I'll say is that you don't have to memorize every single fascial layer, but just keep in mind where they are inside the layers of the body, right? So the fascia is really connective tissue, which is both superficial and deep, and it divides and separates your upper limb and your lower limb as well, which we'll see later on. It divides them into compartments, right? And there's 2 layers, superficial and deep. Superficial meaning higher up, and deep meaning further in to the limb, right? So for example, over here on this diagram on the right, you can see that I've highlighted in blue or green there, the superficial fascial layer, right? And it's located in the subcutaneous tissue. So basically right under your skin is the superficial fascia, and that's going to separate your skin from everything below it, right? The deep fascia, however, is dividing and separating the muscles inside your upper limb. So superficial fascia is higher up and separating the skin from everything below. The deep fascia is lower down, but it separates the muscles themselves into different compartments. And I think you might have already covered this with Jainam and me last time, but the compartments that we have a look at are the anterior muscle compartments and the posterior muscle compartments, which have different roles, flexion, extension, whatever they really require for those joints. Those are produced by the muscles that are in these compartments, right? And also keep in mind that this whole time, the structure in the middle here, over here with the white structures, they're the bones, right? So the bones are the deepest structure always, with the upper limb and lower limb. And then the last thing that you'll probably would have talked about, which we're not going to spend too long on this slide, but we'll talk about later on, is the spaces, right? So spaces are just, as the word suggests, like 3D spaces where you can locate anatomical structures. And so you would have learned about in upper limb with the wrist, the carpal tunnel space. Over here, we're going to learn about some spaces with lower limb as well. But just keep in mind that they're just 3D spaces, but we care about them because that's where some important anatomical structures are. And then finally, whenever you're stuck, think about your body as a big sandwich, or your upper limb and lower limb as big sandwiches, right? Because the layers are the important things you want to keep in mind. So in terms of layers, keep in mind that the most superficial layer, or the highest layer up, is the skin. Then below the skin, you have superficial fascia, then deep fascia, and then muscle, and then bones. So as long as you keep that order in mind, I think it's really helpful to understand or to orient yourself with where you are in either the upper limb or the lower limb. And then finally, not as high yield just yet, but will become more useful when you sort of learn cardiovascular anatomy, which is later on in semester 2, is arteries are going to supply the tissue, and they're paired with the deep vein, where superficial veins run above these arteries and deep veins in the subcutaneous tissue. So on the right over here, you can see that the upper limb had a arterial system, and also a venous system, which was deep and superficial, right? I'm not going to spend too long on explaining that concept because honestly, it's not very high yield. There's only some things you have to remember about it in terms of venipuncture, but otherwise it's quite low yield at this stage. And then the final thing is lymphatics and lymph vessels. They're, again, only important in certain areas, like, for example, draining the breast tissue. That's sort of the only thing you'll really care about for upper limb. And with lower limb, lymphatics is barely even touched at all. So just keep in mind that it's also a separate topic, but you don't want to spend too long on trying to understand the lymphatics of the lower and upper limb. That's going to be more important again in sort of semester 1 of year 2, rather than just at your stage. We learned about the breast drainage. We learned about all of how it's drained and why that's important for cancer spread. But just keep in mind as well that when we're saying that the lymph is drained from tissue, what's happening is it's being drained, then delivered back into your circulatory system. We're not going to explain exactly how just yet, but that'll be something you'll be covering in year 2 again. So I'm not going to spend too long on it, but just to give you context, all that lymph is not just ending up, moving around the lymphatic system. It's going to move through the lymph nodes and then finally be returned back into the venous system and then circulated again. So just keep that in mind. But otherwise, we're going to move on to the hip now. So at the hip, again, we have our movements. So we have flexion, which is, bending your hip up, extension, moving the other opposite direction, and abduction, again, lifting it away from the midline, adduction towards the midline, and external and internal rotation. Now, I know it says internal rotation here, but in reality, there's very little internal rotation at the hip. It's shown here, but most of the rotation is produced by the lower joint at the knee, whereas the hip joint can't really do much internal rotation. Okay, let's have a look at the hip joint itself. So I've put in this little 3D diagram here, which hopefully should orient you better with what the hip joint actually looks like. There's 2 bones that are involved at the hip, right? There's the pelvis bone, which is that big bone up here, which connects to the main spine. So the main spine comes down, becomes this pelvis bone, and then the pelvic bone then forms a joint at the hip, which is articulating with the femur bone or the thigh bone, right? So you have your pelvic bone and your femur bone. Now, with the pelvic bone, one thing they like to ask you about a lot is the parts of the pelvic bone. So there's the ilium, the ischium, and the pubis. So it's 3 different parts. And you can see those parts even better if you look at the side, where you can see those 3 parts very distinctly forming the different parts of the acetabulum, or the socket of that hip joint. And again, with these structures, they've all got very important landmarks on them where muscles can join and attach and form connections, which are going to be important for movements at the hip joint. And also with the femur bone, you've also got some important areas. What I want you to keep in mind from this diagram, probably the most important anatomy, is the head and neck. And the reason is we're going to talk a lot about the arterial supply to the head and neck, as well as dislocations and fractures of the head and neck, which are going to be important for the clinical anatomy later on. Okay, so there's a lot of anatomy with the pelvis which is not going to be entirely relevant for you because again, you're going to be covering pelvis later on in year 2. But for year 1, the only pelvis anatomy you have to be aware of is some of the important landmarks where muscles attach or originate and then extend down into the leg. So with the pelvis, I recommend just keeping in mind a couple of important structures. So the first thing you want to keep in mind is the anterior superior iliac spine. You're going to be talking about that later on with clinical skills as well. They'll usually ask you to palpate it and feel for it on yourself because that's going to be an attachment point for a lot of muscles. And it's a very easily palpatable structure and therefore used often in clinical anatomy for like surface anatomy, sort of to orient yourself with the hip joint. You also have your anterior inferior iliac spine, which you can't really palpate as well, but it's located sort of below because it's anterior, but inferior to the superior one. And you've also got the iliac crest. So this is the iliac bone right there. The crest is the top of that bone, just the top bit over here. And the wing is the inside bit, but we only care about the crest for muscle attachments really. And the ischial spine is another structure which is located on the ischial part of the pelvis, which is and it's over here. You can see that there. Again, it's going to be important for muscle attachments. Ischiopubic rami are these two bits here and here. There's an anterior, superior rami and an inferior rami. And then probably the most important one for the hip is the acetabulum, which is the socket of the hip, right? It's going to be where the femur or the ball of the femur is going to actually lock into. So the acetabulum is a socket, and that's going to be where your hip joint is really going to form. All right, and with the femur, you want to keep a couple of landmarks in mind as well. The femoral head and neck, very, very important because they're going to be important for clinical anatomy. The greater trochanter and lesser trochanter. You might have remembered learning about the tuberosities in the humerus, right? The greater tuberosity and lesser tuberosity. It's very, very similar here. There's a greater and lesser trochanter on the femur, the greater one being on the lateral sort of side of it, very big prominence there. And the lesser one you actually can't see from the front because it's actually a posterior structure. If we turn the femur around and look at the back of it, you'll see there's a trochanter located there, right about sort of below the greater trochanter, inferior to it really. And then you also have a gluteal tuberosity, which is located, do I have it on the diagram here? Nope. Oh, there it is, yeah. So that's the gluteal tuberosity. And again, it's going to be important for attachment of some gluteal muscles, which we'll have a look at later on. But here are some just key structures you can keep in mind. They're not all very important. The most important one is the femoral head and neck, which is really easy to look at because you've got the head being the actual ball and the neck being the bridge between the ball and the rest of the femur. Okay, now in terms of muscles with the hip, you actually have two sets of muscles that act at the hip. There's the gluteal muscles, which form the the gluteal muscle mass. We'll talk about them in a second. There's superficial and deep layers to that. And you also have your thigh muscles. And the thigh muscles have three compartments, the anterior, posterior, and medial. And we're also going to be covering all three of those very briefly. Let's start off with our gluteal region muscles. So with our gluteal region, we actually have two layers, superficial and deep. Superficially, we have gluteus maximus, gluteus medius, and gluteus minimus. And they're got very similar functions. They all do thigh abduction, right? So they're all going to work. And when they contract, they're going to lift up the thigh away from the midline, thigh abduction. So they're called superficial gluteal thigh abductors for that reason. And the other thing you want to keep in mind is you've got another muscle here, which is tensor fascia lata, not very high yield. I wouldn't recommend worrying about it too much. But the most important thing here is the innervation for these muscles. Gluteus maximus is innervated by superior gluteal nerve, whereas every other muscle here is inferior gluteal nerve. It's kind of not that clear with the way I've labeled it, but I'll sort of add it in later as well. But the bottom three muscles are innervated by inferior gluteal, and the top single muscle, gluteus maximus, is innervated by superior gluteal. And all these muscles, they converge on the greater trochanter, or at least on the gluteal tuberosity, and they're going to, again, produce thigh abduction. And next up, we have our deep gluteal muscles. So below the superficial gluteal muscles, if you sort of cut them and put them to the side, you'll see another layer of muscles over here, which is the deep gluteal muscles, which are very similar in the way they sort of attach to the pelvis and then onto the femur. But rather than being these big muscles that can abduct the leg, they're very small compared to the gluteal muscles of the superficial layer. And they instead perform more lateral rotation. So they are used to turn the leg out, if that makes sense. So the lateral rotators of the thigh. And there's, I think there's 5 main ones you have to keep in mind. But with those 5 muscles, they usually ask you in specimens to talk about the order of those muscles. So from inferior to superior, or the other way around, to tell you the order that they go in. And again, because there's so many muscles, it's kind of hard to remember the order. So there's a sort of a mnemonic you can use. So you can use the mnemonic down here to remember that the order is piriformis, then the gemellus superior, then obturator internus, and then it should show gemellus inferior, and then, yep, gemellus inferior, and then obturator externus. And then finally, the last one at the bottom is quadratus femoris. And the great thing about innervation here is that the nerves are very, very well named. The nerve to piriformis innervates piriformis. The nerve to obturator internus innervates obturator internus and superior gemellus. So that's a small exception there. And the nerve to quadratus femoris has innervation for quadratus femoris and the inferior gemellus. So let's keep in mind that all these nerves have nerves that are named after, all these muscles, sorry, have nerves that are named after them. The only exception being the gemellus muscles, which are innervated by the nearby nerves. Yep, that's the main thing for this section. And now we move on to the thigh muscle. So the thigh muscles, again, there's 3 compartments: anterior, medial, and posterior. We're going to start off with posterior because it's probably the most simplest layer with only 3 muscles there. There's semitendinosus, which is this muscle right there, semimembranosus, which is over here, and then also biceps femoris. This muscle is called biceps because it has 2 heads, one which is very, very long, this very long head over here, and you can also see it over here, this long, long head of the biceps. And then you also have a shorter head, which is deeper to it, located further sort of below it, right? And that's a shorter head, which is also going to have the ability to produce the hip extension and knee flexion actions of these muscle groups. And again, with these muscles, they're very, very simple to memorize the innervation for because they've only got one nerve innervating them, which is the sciatic nerve. I'll talk about the actual nerves themselves in a bit as well. All right, next is the medial compartment. So the medial compartment, think about your inner thigh, right? So the muscles on the inside of your thigh, that's the medial compartment. And again, over here, you have 5 main muscles to sort of keep in mind. And all these muscles are all going to produce hip adduction. However, in your anatomy studies, you're going to focus a lot more on adductor magnus because this muscle is sort of special in that it does 2 things. It does both adduction and also it has a bit of extension. So it's got a hamstring component. So if I actually go back a slide, these posterior muscles, right, they're also known as your hamstring muscles because they're located on the back of your thigh and they're colloquially known as the hamstrings, which produce extension of the hip. But this muscle over here, even though it's in the medial compartment of your thigh and therefore should be a hip adductor, it actually does both adduction and extension. Therefore, it's got an adductor component and an hamstring component. And because it has those 2 components, the innervation for it is also split up. So the hamstring part, which is going to extend the thigh, is similar to the hamstring part of the previous ones. They're all going to be sciatic, right? Whereas the medial part, which is going to whereas this part over here, which is going to do adduction, right? That's going to be more obturator nerve innervation. So just keep that in mind that all of the posterior thigh muscles are going to be sciatic nerve, whereas the medial thigh is going to be obturator nerve, the only exception being adductor magnus, which has got a adductor part and a hamstring part. And you can see that clearly in terms of where it attaches. This part's going to contract and pull the thigh in, so adduction. This part will actually contract down here and pull the thigh back, so extension. All right, and the next up, you have the anterior thigh compartment. Also, not that heavy in terms of the muscles. You've only got 5 there. The only thing you want to keep in mind are probably the sartorius muscle and quadriceps femoris muscle. So they all generally produce hip flexion and knee extension, but the only exceptions are the sartorius muscle and pectineus muscle because of the way they attach. Sartorius is an interesting muscle because it starts off sort of lateral, very high up, and then becomes more medial in its insertion. And you can see over here, when sartorius contracts, it produces hip flexion, but rather than doing knee extension, it does knee flexion. So it's doing a very different action to the other muscles up here. That's why it's often called the Taylor's muscle, because it allows you to sort of sit in the Taylor's position over here, where your hip is being flexed and your knee is also being flexed. Whereas the other muscles over here, if you look them up online, they're more so going to be used for hip flexion and knee extension, because they're at the front of your thigh and therefore are going to pull the knee or the bones below the knee, so the tibia and fibula, more anteriorly and extend them. Okay, so the last thing you want to also remember is with quadriceps femoris, it's called quadriceps because there's 4 parts to it. There's 4 different components of that muscle. It's called the vastus lateralis, vastus intermedius, and the vastus medialis. So that's the vastus group of muscles. But then above that muscle group, there's also one more muscle called rectus femoris. Okay, and all 4 muscles together make up that quadriceps femoris muscle. All right. So that muscle group, the vastus group, is going to be responsible for knee extension. And the reason is, you can see that the vastus group actually starts on that femur bone and then goes down to the patella. And that's going to allow it to do knee extension. Whereas the rectus femoris muscle starts all the way up at the ASIS, or the anterior superior iliac spine, and then goes down to the knee. So it can actually produce hip flexion there as well. That's why they've got separate functions, but they all make up one big group. And again, the innervation for all the anterior thigh compartment muscles are going to be femoral nerve. I'll talk about where those nerves start and where those nerves go as well. So here we have a summary of what we've covered so far with the nerves, right? With these nerves we've covered the femoral nerve, the obturator nerve, and the sciatic nerve, and the 3 compartments: anterior, posterior, and medial. So the femoral nerve and obturator nerve, you can see them over here on the diagram in terms of the nerve roots. And the sciatic nerve is on the posterior aspect of the thigh at the back here. But in terms of what they innervate, right, the anterior thigh is innervated by the femoral nerve, which you saw before. The medial thigh, which is going to be your adductors, or bringing the thigh in, are innervated by the obturator nerve. And your posterior thigh, which is going to be, again, which is going to be thigh extension, is more so sciatic nerve. So remember the 3 compartments and the 3 nerves, same as your arm really, where you have a anterior compartment and a posterior compartment. You also have 3 compartments here instead of 2. So remember those 3 compartments and the nerves that innervate those compartments, but also keep in mind the exceptions being adductor magnus, which is innervated by both the adductor component, which is obturator, and the hamstring component, which is sciatic. With the gluteal region, the nerves aren't super important. The only things you want to keep in mind is that in specimens, again, they could ask you about where those nerves emerge. And just for your own knowledge, this piriformis muscle here is a really good landmark to use when deciding which nerve is which. So if you find the piriformis muscle in your specimens classes, then you can have a look above that muscle, and that nerve over there is going to be superior gluteal nerve. Whereas below the piriformis muscle is going to be every other nerve. So it's be inferior gluteal, nerve to obturator internus is going to be there, nerve to quadratus femoris will be there, and so will the big sciatic nerve. The sciatic nerve will be really easy to have a look at because it's probably I think it's one of the biggest nerves in the body. And someone can probably double check that as well in the background, but it's the biggest nerve in the body. So it's very, very easy to see on specimens, and even in sort of diagrams you'll get as well. Okay, so blood supply. I know it isn't super high yield at this stage, but I've put this slide in just for you to use as a reference. To be honest, blood supply will only really make sense when you go into the second half of your semester and learn about the heart and the cardiovascular unit. At this stage, it won't make much sense, but I'm just going to cover it for your own knowledge so that when you're doing specimens, you can have a look at some of the nerves and arteries and veins there and try and have a go at figuring out which one's which. Now, the good thing about the blood supply is it's very similar to the nerve supply in terms of the naming, because again, we name everything based off the nearby structures. So the femoral nerve is named because it's close to the femoral bone, right? The femur bone. So in a very similar way, the blood supply is also very well and aptly named. So if we have a look here, the first thing we're going to be looking at is obviously the heart. That's where all of your vessels come from. But then from the heart, we have this branch called the aorta, which is going to come down and then become the descending aorta. So, yep, the descending aorta, which is this thing here. Then from there, we're going to have another branch called the common iliacs. And there's going to be the left and right common iliacs. And they call the common iliacs because, again, they're close to the iliac bones on the pelvis. And they call the common iliacs, they're called common because they're eventually going to split into 2 parts. So they're going to go from a common part to a shared and split part. That split part is called the external iliac, and then you also have the internal iliac. So you can see here, there's an external iliac going out, and then an internal iliac going inwards. Now, the internal iliac is going to give your arteries to all your gluteal muscles, so obturated artery, superior gluteal artery, inferior gluteal artery. Just keep that in mind that the interior iliac is all to your gluteal area, whereas the external iliac is actually going to keep on running anteriorly and down your leg and turn into eventually your femoral artery. It'll pass under the inguinal ligament and become the femoral artery. We're going to talk about that later on as well, what the inguinal ligament is and where it's located, but it'll become the femoral artery, and then it'll have, it'll go further down and have a branch coming off it called the deep femoral artery. And that deep femoral artery is going to innervate a lot of the muscles around your femur, which we saw in the anterior thigh compartment, posterior thigh compartment, and the medial thigh compartment, as well as innervating the bone itself, which we'll have a look at later. And then finally, you can see that the femoral artery continues further down into the leg as the popliteal artery, popliteal being the back of your knee, which again, you're going to be covering next week in our set about the knee and the thigh, the knee and the lower leg. All this is very, very low yield in terms of actually understanding in detail what's going on. But I'd say have a go at writing down the map over here and see if you can have a stab at trying to understand the pathway of blood flow. But probably the most important blood flow to remember, or the blood supply to remember, is the blood supply to the femoral head, right? That'll be something you'll be covering a lot in anatomy, is that the blood supply to the femoral head is a bit important, because the top of the femoral head, or the top of the ball, is innervated, or not innervated, it's supplied by the branch of the obturator artery. So coming from the internal iliac, right? The obturator artery, it goes to here. Whereas the rest of it, the neck and the lower or the inferior part of the ball, is given blood by the deep femoral, also called profunda femoris, same name, right? Deep femoral, profunda femoris, exact same thing. They supply this part of the femoral head and neck. And it has two branches coming off it, the lateral femoral circumflex, because it's more lateral, and the medial femoral circumflex. And they're called circumflex because they sort of go around that bone, and they innervate it from the front and the back. And we're going to talk about why that's important later on, clinically, when it comes to fractures of the femoral head and neck. But just keep that in mind for now. Don't worry about it too much, because we're going to be reviewing it in a second as well. Okay, now when it comes to spaces, there's a number of important spaces to keep in mind. The first is the obturator canal, right? The obturator canal is located over here on the pelvis in an area called, in the area with a structure in here called the obturator membrane. And so you can see over here, through the obturator canal, the nerves, arteries, and vein passing through are actually very well named: obturator nerve, obturator artery, obturator vein. So there isn't really that much effort to try and memorize those things, because they're named after the canal, right? And under these nerves, arteries, and veins is a membrane bounding it called the obturator membrane. Just keep that in mind in terms of the anatomy there. And this obturator nerve, again, just to clarify, is going to be the nerve that's going to go down to your medial thigh and innervate all the muscles there. Okay. The femoral triangle is another space you want to keep in mind. It's, again, your pelvis is here. The femoral triangle is going to be a structure which allows your arteries, veins, and nerves to sort of communicate and go from the pelvis area down to your leg. And it's kind of hard to see without the full picture here, but I'd say have a look at an anatomy textbook as well, so you can orient yourself a little bit better, or an anatomy atlas. But what's happening here is that you have a femoral artery, femoral vein, and some lymphatic structures here as well. And you've also got a very important nerve here, the femoral nerve, and they're all trying to go from up in the pelvis down into the leg. And the way they do that is to the femoral triangles. That's the area they're going to pass through. Now, if you look over here on the right, I've got that structure laid out for you. So you've got the nerve, then you've got the artery, the vein, and then you've got some empty space here, which is kind of important to keep in mind in terms of the order of those structures. But you've got an empty space followed by the lymph nodes on the right there. And the way that I remembered the order, or the way that we were taught to remember it, is that you can use the mnemonic NAVEL, N-A-V-E-L, to remember that the most lateral structure is going to be the femoral nerve. Then it's going to be the artery, femoral artery, then the vein, then empty space, followed by the lymph node, right? And you've got the borders here as well. The sartorius muscle, which starts off very, very lateral and comes in more medial, is the lateral border. The adductor longus is also over here. And the inguinal ligament is a ligament running down here, forms the top border as well. And the final thing to remember here as well is that this sheet, which is covering all these structures, is called the femoral sheet, right? And it covers everything here except for the femoral nerve. The femoral nerve is going to be outside that sheet. Just keep that in mind. And so that's an important area which we often use clinically when we're palpating and feeling the pulse at the femoral artery. We don't do that in clinical skills because it's a very hard to palpate area, being very close to the pubic region. So we just tend to just talk about it and sort of teach it clinically, and you'll sort of be using it more in hospitals when you go to clinical years. So with your thigh, you also have some spaces. The important one is adductor canal. And there's a diagram here on the left which shows that canal. So the femoral triangle is up here. So if you go back, right, the femoral triangle was a triangle up here. It continues downwards into the adductor canal. And you can see that it starts off with this big, big triangular structure, or like a pyramidal structure. And then the lower part of it becomes this pipe called adductor canal. And it's gonna communicate the femoral nerve, artery, and vein. So the nerve, artery, and vein keep on going down, but then once they go into the canal, their names change because they're now in an area which is located at the back of your knee, called the popliteal fossa. So instead of being femoral nerve, femoral artery, and femoral vein, they're now going to be called the popliteal artery, popliteal vein. And the nerve is also changed now because it's a different nerve altogether, called a saphenous nerve, as well as the nerve vastus medialis. Not very important to keep it to know, but just know that the popliteal artery and vein are the new names for the artery and vein that started off as the femoral artery and vein. The borders are here as well, but I'm not going to spend too long on them. You can have a look at them and confirm that they do match up with what's shown on the diagram. But just keep in mind that the femoral triangle and the adductor canal are actually continuous structures, and they communicate the exact same things, but their names are just changing from femoral artery and vein to popliteal artery and vein. Okay, now let's talk about the clinical anatomy of the hip region. So with the hip region, you want to keep in mind some important pathologies. I've included some of the main ones here, which neck of femur fractures, hip dislocation, osteoarthritis, hip replacement, and the last two there. But everything else which I haven't bolded is either going to be covered in second year in more detail, or is not really high yield, or we'll be covering next week as well. Let's start off with neck of femur fractures. So again, I've got this diagram here from our previous slide. You can see that with the femur fractures, neck of femur fractures, the location of that fracture will tell you the effect. So if the fracture is over here between the two retranacular arteries, right? So right over here, then what's happening is that that fracture isn't actually going to disrupt any blood flow, right? When that fracture happens, the arteries here are not going to be damaged or destroyed. Therefore, blood flow is still intact. And so this part over here is going to have blood flow from this artery, and this part over here will have blood flow from this artery. And therefore, there's a high chance of the bone healing. And so that femur fracture is relatively, is going to heal relatively well. However, if that fracture occurs down here in the neck region, further down, then you're going to actually destroy the retranacular arteries. And if you do that, then blood can't flow from the deep femoral artery into this section here, right? This section is going to have a loss of blood supply because the blood coming from this area is not going to be able to travel up anymore because it's cut off at this region. So this part of the bone is going to have an avascular site, so it's not going to receive blood anymore. And therefore, it's got a high chance of avascular necrosis, where a loss of blood supply is going to lead to necrosis there. And that's going to be important because if that bone rots away and is permanently damaged, then we're usually going to need a hip replacement here to ensure that that hip joint stays stable and doesn't damage, right? And in terms of the cause of neck of femur fractures, the most common causes are falls in older patients. That's sort of a low energy fracture. And a high energy fracture example would be a motor vehicle accident, where really anything can get damaged depending on how you fall and how you get hit, right? Hip dislocations are also important to keep in mind. That's where your femoral bone is dislocated and posteriorly moved in most cases. It can move anteriorly, but the most common way to dislocate is to move posteriorly. And the nerve that's located in that region, which is going to most likely be affected by, is a sciatic nerve. So when your femur is dislocated posteriorly, it's going to hit the sciatic nerve at the back. And the sciatic nerve, we'll learn about later on, is responsible for a lot of your foot movements, specifically the foot the foot drop seen over here is going to be a result of the loss of sciatic nerve function. Okay, so we're going to be covering that in more detail next week, but for now, just keep in mind that hip dislocation will cause damage to the sciatic nerve. And examples of where that can happen is in skiing and football trauma, and again, motor vehicle accidents. The important thing to keep in mind with hip dislocations is they usually occur when your hip is flexed. So that means your thigh is brought up like this, and then you receive a push from this area, pushing your thigh bone backwards. Your femur gets pushed backwards, and then that's how it dislocates. All right, and the last thing here on this slide is piriformis syndrome. So remember we talked about the piriformis muscle at the back of your thigh in the gluteal region, where it's a deep gluteal rotator. That muscle can actually, if it's really, really large, can actually impinge on the nerve below it, the sciatic nerve. And one of the, not the common causes, but one of the potential causes for this occurring is that if you sit for long periods of time, and especially if it's sitting on something like a wallet where it's really pushing into your piriformis muscle, that can make it inflamed. And then the inflamed muscle is going to become larger and therefore compress the sciatic nerve below it. And if your sciatic nerve is damaged or being compressed, you'll feel pain down your leg. And you might also lose some motor function depending on how much damage or how much of an impingement there is. Next up, we have two important concepts: hip replacement, intramuscular injections. The second one is not so important, but I found it very interesting when I was reading through it, so I thought I'd include it as well. The first one, however, will be covered in your specimens tutes, or maybe even your imaging tutes, but probably more your specimens tutorials. With hip replacement, there's two things you have to keep in mind. You either have a total replacement or a partial replacement. Total means you replace the socket and the ball, right? Because remember, at your hip, you have a socket which your ball fits into. The total replacement is where you replace the socket and the ball. So the socket over here is gone and replaced with an artificial one. And the ball of the femur is also gone and replaced with an artificial metal one. A partial replacement is the socket is still fine. The socket can be left intact, but the ball is damaged. For example, from arthritis or from a femoral neck fracture, where it's become avascular or just become very, very rough in arthritis, right? And in that case, you want to usually remove that section of bone, cut it off with a bone saw maybe, and then insert a metal implant instead, which is going to act as your ball, right? And on the right here, you have another clinical anatomy landmark, which is the intramuscular injection site. So at the back of your pelvis and at the back of the gluteal region, you have a site where you can inject, usually vitamin doses and things like that. But what can happen is that if you don't orient yourself properly with the anatomy, you can end up actually piercing the sciatic nerve here, right? And if the sciatic nerve again gets damaged, it can be very, very extremely painful. It's a very, very big nerve and has lots of sensory innervation. It can be extremely painful down your whole leg, but also it can cause some loss of motor function as well. But the sciatic nerve, we want to really, really avoid in these injection sites. So what we do is we actually locate the top quadrant here and avoid that bottom quadrant on the left there. And the way that we can do that in real life is that we use some anatomical landmarks. We first of all find the anterior superior iliac spine. And to find that, you can usually always just like palpate over your hips. And there's a really prominent bony part that comes out the front, which you can feel. And you might even talk about that later on in clinical skills, but that landmark you can feel really, really well. And so you feel for it, locate it, and put your index finger on it. And then you locate the greater trochanter, which is this thing here, right? The femur bone and the lateral aspect of it, which you can usually palpate on thinner people, but can also be palpated if you sort of push in deeper as well. And so you put your hand or your palm over that femur bone and your index finger on the ACIS, and then you spread your fingers out like that, and you form a little triangle there, which is normally going to be a very, very good site to inject your substance, right? And the good thing about this method is that it sort of avoids damaging the sciatic nerve, which is sort of located further down there, right? But again, they're not going to ask you about this at all. I just thought it was very interesting to include, and it's going to be probably more useful in your clinical years, but not so much at this stage. And the last thing to cover probably is osteoarthritis. So osteoarthritis is something that you'll have a look at in imaging, probably more so. And you'll have a look at it with x-rays, and they'll probably ask you with that x-ray to name some of the imaging findings you can see, which indicate osteoarthritis. And when they do, there's sort of 3 or 4 things you want to point out. First of all, in osteoarthritis, what's happening is that your joint is becoming narrower. So one thing you'll notice on imaging is that the joint space over here isn't actually very well defined, and it looks quite narrow. And so one thing you could point out is that you've got a narrow joint space, or loss of joint space even, because you can barely even see a space at all here. The next thing they'll ask you about potentially is osteophyte formation, which is again just formation of excess bone bits because of the damage and the way that your it sort of responds to that damage. Yeah, this sort of excess bone being built up in random areas. And you can normally see that as these very white outgrowths of bone on the femur. And the third thing you can have a look at, sorry, is the subchondral sclerosis. And then the fourth thing is subchondral cysts, both of which are labeled on here. And I've included notes on that in the below as well. So that's it from me for anatomy for this week. I'll now pass it on to, is it Deepak, who's doing autonomic nerves?
No, this is me.
Oh, it's Jainam. Okay, so I'll pass it on to him. And yeah, he'll step you through that topic. And again, if you have any questions for my section or for anything confusing at all, feel free to let me know, and I can either update my slides to reflect that or just try and answer your question within the chat as well.
All right, let me share my screen. Now, I did promise last week, we did a bit about the physiology of the autonomic nervous system. I did promise we would cover the receptors and things in a bit more detail, because we didn't go into in that much detail last time, for good reason, because it's only really that useful when you discuss medications that target those receptors, which is why we're going to discuss it in a bit more detail today. Let me know if you have any questions. I know this topic can get a bit confusing. And one of the things with pharmacology, which is like an added layer of challenge, is that you also have to remember a couple of medications. Now, I will say that you won't actually have to specifically remember drug names, but it's a good idea to know about the drug classes and maybe have one medication that you can pinpoint some of the knowledge to. So if you know one beta blocker, you know one alpha blocker or something like that, that'll be really useful when it comes to exam time. And they give you an example which you're not really familiar with, but you know it's similar to something you've discussed previously, and that'll give you some idea of its effects. So I have like many slides in this presentation. Some include names of medications. I don't encourage you to actually really focus on those, but I would encourage you to at least know where some of these drugs are used, because they're not all used in the same sort of way, even though they might be all alpha blockers or they might be all beta blockers. So let me get started. Now, this is just a recap from my last presentation from last week. We talked about all the different branches of the autonomic nervous system, specifically the sympathetic and parasympathetic. We talked about some of the neurotransmitters that are involved. And what I would encourage you guys to do now is, if you can, like, have a piece of paper near you, just really quickly write down what you remember about the neurotransmitters that are involved and what are some of the physiological effects of each branch. So sympathetic division, if I was to activate that right now, what would happen to my body? Very, very generally. So think about broad systems like the lungs, think about sweating, all that sort of stuff. And then parasympathetic division, think about what would happen there. And yeah, as I said, think about the effector molecules, which are the neurotransmitters. Some of the answers are given here, so that should be helpful. I'm going to give you like 2 seconds, because I'm going to go on to the next slide where I've actually got a summary from our last week. Now, I'm not going to go over this in a huge amount of detail because we discussed this quite a bit last time, but we're going to be focusing on this highlighted section, which is the transmission part. And the reason why is because the transmission is a great place for drug targets. So if you think about sympathetic system, we talked about, or even both, we talked about there's a 2-neuron system, right? And in the middle between those 2 neurons, you've got a ganglion. That ganglion was always going to be acetylcholine with a N receptor. And if you want to think about really quickly, and this is just as a question to you, think about where else you find N receptors, right? Remember that they're found in another branch, which is not really in the autonomic nervous system. For this ganglion, though, it's not really that relevant because when you target, it's very difficult to be able to target that ganglion. We're more so thinking about the end, so like the postsynaptic neuron. Where does it go? That's more of an effective target. And the reason why as well is because they're quite different between sympathetic and parasympathetic. With sympathetic, remember it's noradrenaline, not adrenaline, it's noradrenaline with the alpha or beta receptors with many, many subclasses. And then for parasympathetic, it's going to be acetylcholine mostly, not N receptor this time, it's an M receptor, which again, we will discuss in a lot more detail. So let's start off with the cholinergic neurons. In other words, the neurons that are going to be producing acetylcholine. So remember there are two subclasses to these acetylcholine receptors. You've got the muscarinic and then you've got the nicotinic. Now, for all intensive purposes in the autonomic nervous system, we're really only going to be discussing the muscarinic. And the reason why is because nicotinic, this is answering my previous question, is generally more localized to the somatic nervous system. So they're thinking about neuromuscular junctions and skeletal muscle. And I did mention that they're at the ganglion of some of these autonomic nerves, but they're not really therapeutic targets in those regions. So we're going to be focusing more on muscarinic. As I said, target tissue of the parasympathetic nervous system is where they're pretty much found. And some of the main points you want to know about are that they're metabotropic, they are G protein coupled, and they activate secondary receptors. This is a little bit different to some of the other receptors we'll look at, because if you have a look, let me get my cursor up. If you have a look at some of the processes happening within the cell, you've got your neurotransmitter binding to the receptor. And again, ignore all the actual proteins involved, but the G protein is sort of important because all that means is that you've got this cascade happening within the cell, and it indirectly is going to activate an ion channel. You'll see why this is important when we come to the next type of receptor. The main point I want you to get out of this is that this is not susceptible to what is called a depolarization blockade. So what I mean by depolarization blockade, actually, I won't go into it now because it's going to come up in a couple of slides. Just remember this for now, bookmark it in your mind. It's not susceptible to depolarization blockades, unlike nicotinic receptors, which are. Because of this, what it means is that the antagonist and agonist drugs, remember antagonist means it binds to it without actually activating it, or it just blocks it. And then the agonist is actually going to activate it and cause some sort of effect. Both of them will not have the same effect. So the agonist is going to, of course, because it's activating, it's going to cause an increase in the parasympathetic system. So again, think about all the effects that are going to happen when I activate the PNS. And then the antagonist is going to block the parasympathetic. And really crucial to this entire topic is that, remember, usually in a normal human being, in a physiologically normal human being, you've got parasympathetic and sympathetic being balanced. So if I decrease parasympathetic, now suddenly my sympathetic is going to be a lot stronger. And so I'm actually going to start to experience more sympathetic responses. And again, think about what those effects might be. Now, here's a good summary slide for your revision. When you're thinking about the different subtypes of receptors, there are generally 5, and there's probably going to be more discovered. But for now, we're thinking about 5 main receptors. And if you want a nice way to sort of summarize all of them, just remember that M1, M3, and M5 will generally be, so all the odd numbers basically, they will generally be more stimulatory effects. And M2 and M4, the even numbers, will be more inhibitory effects. Now, if we're thinking about the actual receptors and what they do, it's actually really straightforward. With M1, we're thinking about mainly the central nervous system. And anytime I say central nervous system, you can kind of just ignore because we're not really discussing the CNS medications yet. We're mostly thinking about peripheral nervous system. So just remember that it's to do with CNS. But it's also a little bit about gastric glands and salivary glands. With the M2, this is probably the most important one. You've got cardiac muscle and a little bit of CNS to go along with it. But it's, for the most part, it's going to be cardiac. So if I'm thinking about parasympathetic, I'm thinking about rest and digest. I'm sort of slowing down, right? So that means that M2, if I activate it, it's going to slow down my heart rate and my cardiac output. M3 is mainly your smooth muscles and a little bit about the secretory glands. And then M4 and M5 really like they're still being investigated. So if the scientists don't know it yet, that means we don't need to know it yet. But just remember that it's CNS. They have been, I think, implicated in a couple of CNS related disorders like Parkinson's and things. But for now, we don't really know what they cause. A really easy way to remember some of these, or at least the main important ones, because M4 and M5 are still up in the works, if you want to remember M1, M2, M3, just remember that you're going from your brain, so that's the CNS M1, to your heart, which is M2, and then down to your bladder. Of course, bladder is not, it's a very general way of thinking about it, but I'm using bladder as an example because, of course, it fits that order, as well as the fact that the bladder does contain smooth muscles and secretory glands. So if you remember that, you know that tissues like the bladder will have the M3 receptor on them. Really, again, I'd encourage you to think about the actual effect of the PNS innervation to each of these different receptors. Now, nicotinic is slightly different. Remember what I said is that it's mostly at the neuromuscular junctions, and obviously it's also going to be at the autonomic nervous system ganglia, but they're not very useful for our pharmacology. The difference is that the previous one was metabotropic. This one is ionotropic, and the way I like to think about it is because metabotropic will be indirectly linked to an ion channel. So you've got this sort of cascade happening at the bottom that then opens the ion channel. So it's a bunch of metabolism processes, whereas ionotropic is actually very direct. All it does is the neurotransmitter binds and it directly opens up that ion channel and allows typically Na+, but I think there's some calcium, there can be potassium, all these different things can happen, but generally it's going to be sodium for our nicotinic receptor. Now, this sort of channel is very susceptible to depolarization blockades. And it's a very complex sort of physiological idea, like the depolarization blockade. But in the next slide, I'll give you a little bit of an explanation just to kind of consolidate what that means. For now, just remember that when metabotropic receptors have antagonist and agonist having very different effects that we just generally expect, with the nicotinic, they will actually have the same effect and it will both be inhibitory. So that sort of makes sense for the antagonist. The antagonist is trying to block it anyway, so that's going to be inhibitory. With the agonist, what happens is that you kind of have the agonist binding, and it keeps this sort of end plate open, or the receptor open permanently, without allowing other neurotransmitters to bind. What that does is it causes continuous activation of whatever tissues at the end. So you kind of get like this sort of extreme contraction, and it's going to kind of be stuck in that contraction phase. So it contracts once and it's stuck. Now, what that means is that nothing else can bind and stimulate more contractions later on. This is not something that you see in metabotropic, because you will just get binding of the agonist and it will have one effect and then it'll pop off. And then you can have another neurotransmitter binding, it'll have some effect and then it'll pop up once it's done. Okay, so that's a very important thing to keep in mind when we're thinking about the actions of medications. So here's just that idea for you at the bottom. Now, again, you think about subclasses, it's a little bit simpler than metabotropic because we've only got two subclasses, and it's basically what we've discussed. The NM subtype is the one at the muscular. So NM for muscular. It's going to be, so they're both nicotinic subtypes. This one's muscular, found at the NM junction. The NN is the nicotinic, it's not supposed to be muscular. It's more at the autonomic ganglia. I'll fix that up. But it's supposed to be within the autonomic ganglia, again, not crucial for pharmacological effects. And here's that explanation that I gave you previously, if you want to have a read. Unlikely that they'll actually ask you what the definition is, but it's extremely important contextual knowledge for when we're discussing the medications. All right, and again, you may have covered this last semester, but this is going to become a little bit important for when we discuss one particular medication. And it will require some knowledge about how acetylcholine is actually regulated at the junction where it's released. And the main thing I want you to remember is that acetylcholinesterase is the enzyme that will degrade acetylcholine just to make sure that it's not having too much of an effect. So it's not just continuously activating whatever target tissue it's at. And again, just a side point, it's very, very rapid. So usually it happens within less than 1 millisecond due to it being very, very highly concentrated at that synapse. All right, now where are these located? I think in your workshop that you'll have, or you may have already had, you will have this nice table. And that will summarize pretty much where all these innovations happen. So which organs they are at and what the response will be. So I won't talk about this too much. But as a quick summary, remember that M2 is in the heart and I encouraged you to think about this before. Hopefully you thought that if it's in the heart and it's causing parasympathetic stimulation, it's going to reduce the beating rate. With M3, it's generally found in most of your other organs, including in the eyes. So you can see all the like eyes, you've got the lungs, you've got the gut, you've got the bladder. Most of the other tissues basically will be M3. And again, think about it. So like with the lungs, if I have parasympathetic, I don't need my airways to be completely open because I'm not running from anything. So I can just make it constrict. And for the parasympathetic system, that's fine. Same for all these other ones. Now, I've put a section for other because there are three main exceptions or just things to keep in mind because they can kind of trip you up. So they don't really follow these two main categories. For sweating, this is probably one that is a little bit strange. It's actually a sympathetic response. So if you think about rest and digest versus flight or fight, in flight or fight, you want to be sweating, right? Because you want some thermoregulation. You're going to be you're going to be running, right? And if you think about running from a bear, you're going to be sweating quite a bit. So it technically is a sympathetic response, but it actually happens through an M3 receptor. So keep that in mind. It's like a mix of both my sympathetic and my parasympathetic response, which is why I call it, or what we call it, is a sympathetic cholinergic. So if you see that term, and I don't think it's just for sweat glands, there might be other glands, but for our purposes, sweating is the main sympathetic cholinergic you want to keep in mind. With blood vessels, you will see this in the next section. You will see there's a cross here, and that sort of indicates that blood vessels don't have any parasympathetic innervation. They will only have sympathetic innervation, and it will control both your dilation and your constriction of the blood vessels, depending on where the target is. And then finally, the lungs has, although it's a tick, right? It does have parasympathetic innervation, and it has sympathetic innervation. It will not be directly having any nerves actually going to the tissue. What you'll have is you'll have blood vessels going to the tissue that will carry your noradrenaline, that will carry your acetylcholine to the lung tissue instead of it being through a nerve. Okay, so these are the three main sort of exceptions that you want to keep in mind, and we will repeat this again when we come to parasympathetic, to sympathetic a little bit later on. Okay, now clinically relevant things. If you have too much or too little of a drug, then you can get over exaggeration or undershooting of some of your parasympathetic responses. So let's talk about first cholinergic toxicity. So this is when you have too much parasympathetic stimulation. And basically just take all the things you know about what the parasympathetic system does and times it by 100, and that's what you'll get here. So in this picture, if you kind of remember what this person looks like and some of the labels, then you will know sort of what this system or this sort of toxicity does. If you're not as visually oriented as I am, then there are some mnemonics that can help you to just remember these. And I think I might have touched on this in the chat last time. The one that most students use is dumbbells. So we're thinking about things like diarrhea, urination. Of course, parasympathetic system is really big on being able to like go to the toilet, right? Because you're not running from anything. So you can let go of some of your digestive waste. So you're going to have a lot more of that through diarrhea and urination. You will have meiosis, which is excessive. So like if you think about, again, the parasympathetic system, you don't need to open up your eyes or your pupils too much to be able to let light in. So you'll have constriction of your pupils or pinpoint constriction if you have too much parasympathetic. B, and E are going to be bradycardia. So that's slowing down of your heart rate. Bronchoconstriction, so constricting of your airways. And emesis, which is just another fancy word for vomiting. LLS will be lacrimation, which is crying. Lethargy, so you feel really, really tired. And then salivation, because you can afford to eat when you're not running. And the reason why this can happen is you can have exposure to certain organophosphates, or you can have exposure to insecticides. And that can be inhalation, ingestion, or direct physical contact. So in an emergency setting, when you have someone presenting with all of these sort of symptoms, you're automatically thinking, oh, so they may have had some contact with some sort of poison, like an insecticide or an organophosphate. The opposite of this is just going to be anticholinergic toxicity. So you have something, and typically this will be the medications that you administer. So we'll talk about the medications later on. If you decrease your parasympathetic stimulation, you will have too much sympathetic effects, because that branch is now going to be dominating. So again, think about everything we discussed for sympathetic and just times it by 10. But if you want something just to like remember some of the main effects, think about your peripheral effects and think about your central effects. And remember the fact that, remember what I said between M1 and M5, you've got some of your receptors like a bit of M1, M4, and M5 that are within the CNS, and then the other ones are more in your organs. That's kind of why I've split it up into peripheral and central. For peripheral, you'll have things like your face will be flushed, so you'll have a really red face. I think that's, yeah, so there's some like nice phrases here to remember these. So red as a beet, so that's flushed skin. You've got dry mouth, so dry as a bone. You've got blurry vision, so blind as a bat. Tachycardia, constipation, those ones are quite easy to remember based off the SNS effects. And then central effects, these are a little bit harder to explain, but just think about if I was to block those specific receptors in the CNS, I may get some sort of imbalances with the way that I'm thinking. So I might get confusion or agitation, and that's mad as a hatter. So you'll be quite confused. All right, and as I said, the reason why is usually iatrogenic. So you give too much, either the patient takes too much or you give too much anticholinergic medications. And speaking of them, we're going to talk about, or at least I'm not going to really talk about these too much, because I feel like this is just a very brief summary, and I would consult ePharmacology for more up-to-date sort of information and some of those related websites to kind of learn these. The way I learned this, and just like my general tips, is that I would try and either draw a picture of for myself to remember some of the modes of action, some of the side effects, or I would try and break down the word into something that is like a really funny story or something, so I can remember some of these things. So keep these in mind and come back to these slides later if you want to remember some of the actions of these. You might have already seen these bottom two last year when we're talking about muscle relaxants, so rocuronium, succinylmethonium. These other ones though might be a bit new, so they're the antimuscarinic drugs. If you need a bit of help with remembering these, I have like a list of mnemonics and things that I've made for myself. So let me know and I can post them up somewhere if that's something that interests you and you're finding it difficult to remember these. And here's a couple of other ones. Just a note, there are some of these drugs that you will discuss in a lot more detail probably next year. So you will have gastrointestinal medications, respiratory medications. And as a general note, some of these drugs will be used in more than one setting. So you might see later on, you'll have antidepressants and things. That's because they have some side of like other effects that are not so much to do with the action in the autonomic nervous system. So if you see those, just make a note of it, but keep in mind that you'll probably come across it again later on. So it's a very iterative process to understand these medications. All right, now on to part two, adrenergic neurons. So we're talking about adrenaline. And remember that adrenaline is generally the type of neurotransmitter that's mostly in the sympathetic response, right? And we have two types. We've got the alpha receptors and we've got the beta receptors. With the alpha receptors, if you remember nothing else, just remember that it's mostly to do with contraction. Beta will be mostly to do with dilation. There are a couple of exceptions, but for the most part, this holds true. There are two subtypes. There's alpha subtype and alpha 1 subtype, and there's alpha 2 subtype of the receptors. Alpha 1 is going to be, so you can see alpha 1 here. It's going to be at the postsynaptic nerve. And generally what that does is things like vasoconstriction, GIT contraction. So again, it's constricting. And the weird one is pupil dilation. This took me a lot to kind of wrap my head around. Dilation doesn't make sense, right? Because you're thinking contraction. So we're thinking maybe the pupil will become smaller. But the reason why it becomes dilated is because there are actually muscles on either side of the pupil that will constrict and make that pupil wider. So whenever I have constriction of those muscles, remember we're talking about the muscle, it's going to constrict, pupil will dilate. So that's why that one seems a bit off, but it still makes sense. Alpha 2 is generally, and I know it sort of shows alpha 2 here as well, and that's a very minor part, but generally for the most part, it's going to be in the presynaptic terminal. So basically it's going to be on the same nerve that's releasing the noradrenaline. And what the use of that is that it causes autoinhibition. What that really means is you've got kind of negative feedback where the adrenaline kind of comes back, attaches to this, and it causes less noradrenaline to be released. And that's just a way to control it so you don't get too much noradrenaline being produced. Okay, so those are the two main types. The beta receptors, as I mentioned, are generally dilation effects for the most part. And there are three subtypes. The first two are probably the most important. The third one is also a good one to remember. If you want more information, you can probably you can look at this diagram, but really for your purposes, this is enough. So beta 1, I really like these naming because obviously alpha doesn't really make too much sense, but for beta, you're thinking about beating and then you've got one heart, so beating heart. So there's going to be heart and it's going to cause it to beat more. So it's going to be more sort of contraction effects. With the beta 2, so we're thinking again, sort of beating, doesn't really make sense too much here, I guess, but you've got 2 lungs. So it's going to cause effects in the lungs, which is the bronchodilation. Additionally, there's going to be some vessel vasodilation. So going back, remember alpha 1 is going to be vasoconstriction and beta 2 is going to be vasodilation. That's a very crucial thing to remember. And if you recall back to the slide where I said there are only going to be adrenergic innervation to blood vessels, this is what I mean. There is no M receptor or N receptor on the blood vessels. It's just because of the subtypes of alpha and beta. And then beta 3 is another crucial one to remember. It's the adipose tissue. So it's going to cause you to get more energy out of your fat stores through lipolysis. And this is something you would have covered in biochem. So as I said, remember, you have 1 heart and 2 lungs. So that helps you remember beta 1 and beta 2 really well. And this diagram pretty much sums it up. Okay, now again, as we did with the previous receptors, we're going to also just briefly discuss how we regulate noradrenaline, because that's a semi-important drug target in some spots. So if you think about noradrenaline being released, remember we had that alpha 2, which is helpful, but it's not enough. So what we have is some enzyme mechanisms that will break down the noradrenaline that's in excess and prevent more stimulation. This is either going to be in the first or the second cell. So this can be either of these cells that do this. And generally the enzymes are MAO and COMT. You don't need to remember these. It's just to kind of quantify what these acronyms mean. So monoamine oxidase and catechol O methyl transfer. Cool thing is that cocaine, and if you think about the effects on someone who takes too much cocaine, what it will do is, and why it does that is because it inhibits this uptake or reuptake of noradrenaline, which means that we have too much noradrenaline, which causes increased sympathetic response, like pinpoint pupils and all the things we've sort of, sorry, not pinpoint, dilated pupils and all the things that we've discussed before. Okay, now very quickly, again, in your workshop, you will find this table. It's very, very useful. And I would recommend just keeping a copy of it as you go through your unit on Pharm. You've got the alpha 1, and I'm only discussing the important ones. You've got the alpha 1, which causes contraction of the radial muscles. This is what I meant with pupil dilation. So it contracts those muscles, causes the radius of the pupil to increase, and you get more light in. Vasoconstriction, it's not so, it shouldn't really be vasodilation here. It's more beta 2 that's doing the vasodilation. The thing you'll find is that there's no perfect way to categorize these. So alpha 1 can actually do a little bit of both, but for the most part, I would stick to this table and the previous table. So alpha 1 does mostly vasoconstriction and beta 2 does mostly vasodilation. Also constriction of urethral sphincters, which causes them to open up, to close, and then you urinate less. Beta 1 is going to be, as I said, 1 heart, so higher rate and force of heartbeat, and beta 2 is going to be your 2 airways or your 2 lungs, so it's going to cause bronchodilation. And as I said, for some of the exceptions, look back on the slide that I made for cholinergic receptors, so things like sweating blood vessels, lung innervation. And then if you want more specific stuff, just, as I said, really, really sit down and understand each of these effects, because you may get something like this come up in an exam. Now, I'm not going to go over this too much. So you've got different drugs targeting each of these receptors. And I've broken it up so that it's a bit easier to understand. I know the lecture can go, like, there's a lot of stuff in the lecture, but this basically summarizes everything that you will need to know for your exams. You've got the alpha adrenergic receptors and you've got the beta adrenergic receptors. And the important drug targets are alpha 1, alpha 2, and beta 1, beta 2. You've got agonists and antagonists for each of them. And remember that for these ones, you get them having actually like different effects, right? So an antagonist and agonist will have slightly different effects. I've put a couple of examples. So as I said, you're not going to have all alpha 1 agonists doing the exact same thing. So for alpha 1 agonists, generally it's going to be decongestants. So with the nasal or ocular decongestants, because of their ability to cause vasoconstriction. So it prevents excessive blood flow to a region or like edema building up there. Let's find one that's a bit more interesting. Actually, they're all interesting. So I guess you can read over these in your own time. Just remember some of these names if you can. So if you ever see the word phenylephrine, you know it's sort of in this category. Now, the most important thing to take out of this, and this is more so clinically, when you go into the clinic, remember, try not to give, or not try not to, just never give beta blockers to an asthmatic patient. And I want you to think about why this is the case. So remember, asthmatic patients, they have already a fair degree of bronchoconstriction. It can be either allergic or non-allergic, right? But they've got already quite tight airways. Now, if you give a beta blocker, so you give a beta blocker, and remember what your sympathetic system is trying to do. It's trying to open up your airways. So if you're blocking that, you're going to cause even more constriction. And this is really bad, right? Because it can even cause death if you don't get any oxygen into their body. You can cause ischemia to all these different parts of your, like your heart, your brain, things like that. So it's very, very crucial that you avoid this. And you probably will get a question on this just to make sure it's hammered home. And it's crucial also to remember that it doesn't matter how selective it is. So I did mention that bronchoconstriction is mainly through, or bronchodilation is mainly through your beta 2, because you've got 2 lungs, but it doesn't matter if it's a beta 2 blocker or if it's a beta 1 blocker. They can actually, it's not very selective. So beta 1 can also bind to a beta 2 receptor and cause this sort of effect. So just completely avoid any beta blockers in any of these asthmatic patients. Again, I'm not going to go over this. You've got many sort of drugs to remember. Don't worry too much about remembering every single aspect of each of these, but I would still recommend having a brief idea of where they're used. So you've got 2 sort of alpha blockers here, and generally they're used for BPH, which is a benign prostatic hyperplasia. So you've got part of the urethra going through the prostate, and if the prostate enlarges, it can kind of obstruct the urethra. And if we want to, and this can be problematic for urine outflow. So if we want to stop that, we can try and improve urine outflow through these sort of medications. Now, just a brief note, some of them will be more specific than others. So for tamsulosin, it's actually more specific to alpha 1A and alpha 1B receptors, which is more specific to your bladder. That's going to be a little bit better for BPH, and it's going to be better because it's not going to have too many other side effects. So if you remember these basic principles about how selective something is, then you'll be able to understand what the effects are going to be later on. As I said, some drugs will have different sort of things happening. So this is because of serotonin. But for the most part, just remember what the sympathetic parasympathetic is. For this one, it's urge incontinence. And then you've got some medications that act on the degradation of those molecules. So this is something, so if you think about the process by which you generate adrenaline, if you stop an enzyme that is producing the adrenaline, you will have reduced adrenaline, and like part of the process is also dopamine that comes before. So if you block dopamine conversion, you'll get more dopamine, and that can be good for people with Parkinson's who have less dopamine in parts of their brain. Yes, I think that's it. So with these medications, again, try not to stress too much. There will be a lot, like I'm reinforcing some of these things this year with some of the medications in gastro and respiratory. So don't stress too much. Just remember the main drug classes, and you should be fine. So hopefully I haven't scared you too much through this presentation. Again, if you have any questions, let me know in the chat, and I will now pass it on to Deepak to walk you through, I believe, anesthetics.
Yep, thanks for that, Jonah. Let me screen share. Okay, so we're going to be talking about modulation of nerve conduction, and specifically how anesthetics work. So I want you guys to sort of think back to the action potential. And there were a bunch of different steps when it comes to generating membrane potential, the hyperpolarized state, the depolarized state, so on and so forth. And initially we had sodium channels activate, and then sodium channels deactivate, and then potassium channels activate, and eventually all channels reach the steady state that they're usually at. For anesthetics in particular, we're going to think about the sodium voltage gated channels and specifically the intracellular region of those channels. So local anesthetics bind to this intracellular region of the sodium voltage gated channels and cause reversible inhibition of the neuron. Reversible is important. Obviously, we don't want to inhibit the nerve conduction forever, but it's also important to understand that even though we cause reversible inhibition of one particular segment of the neuron, that stops the all or nothing response at that section. And if you guys remember how nerve impulses are conducted down a neuron, you sort of need adjacent depolarization to cause further adjacent depolarization. So it stops downstream impulses from that point onwards, sort of thing. You can sort of see how, like on this diagram here on B and C, how the local anesthetic sort of has to cross the membrane layer, and once it's intracellular, it binds to the inactivation. It causes the inactivation gate to close by binding to its specific binding site. Now, there are two main types of anesthetics. We're still talking about local anesthetics, but within that, we have amides and esters. So you guys might remember a little bit about this from chemistry, probably like high school stuff. But if you look at the diagram on the right, it sort of illustrates what these two anesthetics really are. So we start off with a benzene ring, which is a common ring that is lipophilic. Lipophilic meaning it likes fat, so it's able to dissolve in fat because it's a non-polar segment. We have an intermediate chain. Now here's where we get the option of ester or amide, and then we have an amine at the end, which is hydrophilic. So we have a lipophilic end and a hydrophilic end. And in the middle, we get to choose between amides and esters, and they cause a bunch of different characteristics to differ when it comes to the anesthetic itself. So for example, the amides, longer lasting, esters are short lasting. Amides are metabolized in the liver by P450 enzymes, but esters are metabolized in tissues by tissue esterases. Both are renally excreted, and we can talk about the naming in a second. But one way I like to remember this is because the amide has to go to the liver to be metabolized, I just think of it as longer lasting, although that's not actually how it works. But yeah, so when it comes to naming, amides, you can think of, because it has an I in amide, the names for amide anesthetics have an early I. So for example, lignocaine has an I after the L, but esters have no early I. So emethicaine does not have an I here. That's actually convention. So it's very useful to remember it that way. Now, there's a bunch of different factors that affect the action of these local anesthetics. And we're going to talk about these different factors in a second. So we first start off with lipid solubility and potency. Right, so we just talked about how the anesthetic needs to migrate inwards through the cell membrane. And in order for this to happen, it needs to use its lipophilic abilities, right? Because it needs to dissolve through. And this means that an anesthetic that's more lipophilic will have more potency because more of it can transfer across at a greater rate, sort of thing. This allows it to have sort of like better action, or allows it to stop the nerve conduction for longer. And you can sort of think of it on the reverse side. So if we have a smaller cell membrane, equally, it's going to be more susceptible to blockage. So smaller and unmyelinated fibers are more susceptible. And there are a bunch of different types of nerves and axons when it comes to the structure in our nervous system. And if you look at the diagram on the bottom right, we can sort of categorize different axons to different types based on the thickness of the membrane and the myelin sheath. So for example, we have A alpha, A beta, A delta, and then C fibers. So C fibers, as you can see, are the ones that are the most thin, and they also conduct pain. So that means that when we if we were to use a anesthetic, the fiber that will first be blocked is going to be the C fiber, and then the next one that's going to be blocked is A delta, which is going to be cold and warmth, and then the next one would be touch, deep touch, and pressure and motor, which is like A beta fibers. Now, if you think about the order of recovery, you can sort of reason it using a similar type of reasoning. So the first one that will recover would be probably A beta, right? Because for the C fibers, since it's so lipophilic, it's probably going to be in there for longer, sort of thing. Since more would transfer across, so more would need to leave. But in A beta, not as much would transfer across, since it's less lipophilic. I mean, it's not less lipophilic, but it has a larger membrane barrier to cross, so it would recover first, and then A delta, and then C. So the order of recovery would be like motor, and then pressure, and then touch, temperature, and then pain being the final one. Okay, one more thing quickly. So since the order of blockage allows us to stop pain first, that allows us to have anesthetic action that stops pain but allows for other stuff, if that makes sense. Or like predominant action being the pain blockage, yeah. So the next one on the list was ionization status and pH. So anesthetics local anesthetics are weak bases that have a pKa of 8 or 9. So if you remember what a pKa is, that's the pH at which the local anesthetic would be 50% dissolved and 50% in the original form, like ionized. So at physiological pH of, I think it was like 7.4, it's going to be largely ionized. And if the tissue is inflamed, it's going to be an acidic environment. And since it's more acidic, the weak base would want to ionize more to neutralize. So the local anesthetic would be further ionized. Therefore, at inflamed tissues, the anesthetic would be less effective, because we don't want it to be ionized because it makes it less able to cross the barrier. Therefore, at basic situations where there's a high pH, when it's largely unionized, the local anesthetic effect is more effective, since it's able to cross the barrier more easily. And as a rule of thumb, we can think of it as weak acids are easily absorbed in more acidic conditions, weak bases easily absorbed in more basic conditions. And yeah. So even if it is ionized, even if it's not ionized, as you can see here on this diagram, in the cytoplasm, it ends up being reionized to bind to the receptor site. Just for, I don't know if you guys want to know that. So the third one was use dependence. Now, what is use dependence? So local anesthetics only really block sodium channels that are open or inactive. So open means active, right? Like it's actively allowing sodium to enter. And inactive means it's in its sort of inactivated form when we first close the gate. So it's not in its resting form, since that's distinct from being inactivated. If you guys remember from the depolarization sort of graph, there's a period of refractory period, and that would correlate to the inactivation of receptors. So since they only function when it's open or inactive, then the degree of the block is dependent on the use of these neurons. Since when it's open, it's being used, inactivated is just after use. So nerves that are more, that have an increased frequency of firing or generally are used more, have an increased susceptibility to blockage by anesthetics. So there's a couple more. So when it comes to electrolyte concentrations, I wouldn't worry too much about this, but there was a brief sentence that was stated on the slide. So just keep in mind if your lecture goes into depth. For vasoconstriction and vasodilation, that is pretty significant, because we can think of the vessel surrounding the site of application of the local anesthetic to change the effect of the anesthetic by either like, if it's going to be vasodilated, it's going to increase flow to that region, and that's going to cause systemic distribution of that anesthetic, which will decrease the local effect of that anesthetic, since it's not going to stay in the site of action for long. And it will increase systemic effects, which sometimes we don't really want. So vasoconstriction will decrease flow, increase resistance, and limit systemic circulation, and that's going to prolong anesthetic effect. So for example, adrenaline and fellipressin is added with local anesthetics exactly because we want to decrease systemic effects and prolong the local effect. All right, so adverse effects. So we just briefly talked about how we don't really want systemic effects, right? So we have what we call dose-dependent systemic effects. Dose-dependent because it's dependent on the dose. So for example, restlessness, tongue numbness, or having a metallic taste, shivering, convulsions, respiratory depression. And it's essentially like in descending order of like dose dependence, I believe, since respiratory depression is one of the most severe consequences of having a systemic effect. We have cardiovascular effects as well. So that's myocardial depression and conduction block. When we refer to depression, really mean the decreased functioning of it. So decreased functioning of the lung and of the heart. Conduction block, which is reduced which both leads to reduced contractility and vasodilation. All right, so there's a bunch of different methods of administration of anesthetics. So topical or surface administration is just injection at the surface of the body. Infiltration is injection into tissues to reach nerve branches. So yeah, intravenous regional is kind of for different things like limb surgery, nerve block. So this is directly injecting very close to nerve trunks or near a plexus, and this is for general local surgery or dentistry. Epidural or spinal anesthesia is in your central nervous system, surrounding it is layers of dural matter, and you can inject it into the epidural space, which will block the spinal roots directly, and that's for like stuff like childbirth or more like severe stuff. All right, so we have a bunch of different drugs that we probably should know. Two amides and esters. So lidocaine or lignocaine, it's an amide, and bupivacaine is an amide as well. Only difference between these two really is the cardiotoxicity of bupivacaine. Yep, and emethicaine and tetracaine. Again, this is an ester, and it has another side effect profile. But yeah, that's it for me.
All right, I'm back. And with a new topic, which is basically everything we've been discussing, but in a clinical setting. So I'm going to be discussing how we actually do peripheral nervous system histories and exams. Now, there are a lot of slides here, and I'm not going to discuss every single thing. So I would encourage you to actually go over this in your own time. This is designed to be sort of a quite in-depth presentation. So if you want to make your own notes of this, that's perfectly fine. I've tried and put pictures in, and I've tried to organize it in a way that's really, really easy to follow. So one of the major things I'd encourage you to do is take this presentation, download it. And if you have someone you can practice with, work through each slide and try each of these maneuvers or tests with them so that you understand what the order is going to be. Now, compared to your MSK sort of exams and histories, this is a little bit different. And the reason why is because with MSK, you do all these like palpation, you do like measurements, and then you'll do movements and things like that. With the neurological, it's a little bit different. So I'm going to go into how those differences arise in just a sec. But just a very brief section on history taking. There are a lot of questions that you can ask, and I wouldn't encourage you to ask every single one. I mean, at this level, probably it's a good idea. So if they say, take a neurological exam, probably run through everything that you can remember. And I know there's a lot of questions. So this is a mnemonic that I don't remember where I got it from. I think it might have been from another PSP or online. It's a really, really nice summary of all the questions that you need to ask. And the mnemonic is head swing. So you remember things like headache, trauma with loss of consciousness for H. For E, it's basically all the 5 senses: so eyes, ears, mouth, nose, taste, everything. A, you think about anesthesia, paresthesia. So we're thinking about loss of sensation or sort of pins and needles. With D, we're thinking about dizziness. So like almost at the point of losing consciousness, vertigo, where everything looks like it's just moving around really strangely. S, thinking about seizures and tremors. W and I, we're thinking about weakness or incontinence. So they don't have control over their bladder or their like their toilet region. With N, we're thinking about neck stiffness and pain. And then finally for G, this is really crucial when it comes to exam, we're thinking about changes in the way that they're walking, so their gait disturbances. And this is generally something you can see as soon as they come into the room, but you also want to ask them if they've noticed anything in their own life. If you're not a fan of acronyms, there's also a way you can remember this, thinking about the systems. And I'd still remember this or understand this at least regardless, because it kind of tells you why each of these questions are being asked. So we're thinking about, first of all, central nervous system pathologies. So we're thinking about the brain, either the brain, the sensations, like so the nerves providing sensation, or the meninges, so the layers around the brain. So headache, loss of consciousness, drowsiness, and so on. Sensory, we're thinking about the disturbances in all those 5 senses. And meninges, because the meninges is not just around the brain, but also they kind of go down the spinal cord through the neck. You can also get neck stiffness and some photophobia, or fear of, or like pain when you're looking at light. Peripheral nervous system questions are a bit more straightforward. So you've got the sensory stuff, you've got numbness, tingling, burning, and so on. You've got motor things where they have movements that they're not able to control. So you've got things like tremor, you've got stiffness, and also an inability to walk normally. I think you actually have a whole lecture on gait disturbances, so I won't go into this. There's a lot to take in for gait. There's all these different types, but in general, just remember if something's wrong with the gait, something's wrong with nerves, and you want to think about, is it in the central system something's wrong, or is it in the peripheral system? And then finally, for autonomic, if you just think about everything I've talked about just then with our autonomic physiology and pharmacology, all the effects that, all the things that could go wrong, the color of your skin, so you might get abnormal flushing, so redness, temperature either being too hot or too cold, excessive or not enough sweating, bowel or bladder dysfunctions, all of these and more can be a pointer towards autonomic problems. This is not something that we might have got into a lot of detail with MSK, but it's really important to just remember that when you're taking a history, it's crucial that you try and find out if there are any risk factors that you can ascertain from the rest of your history. So it's not just your systems review and then you go to all your normal stuff like past history, drug history, as you would normally do. You may want to ask a few specific questions based on your patient's risk factors. So in past history, you might be thinking about some infections that can actually result in, so for example, inflammation of the meninges around the brain, so meningitis, surgeries around the head or neck or the spine that could damage nerves. And then you go down this list. There are some things you will learn a little bit later on. So malabsorption, for example, if you don't have enough vitamin B12 in your diet, that vitamin is critical to be able to form the myelin sheets that are around your nerves. So if you don't have that, you might have slow or reduced conduction through your nerves. Then with drug history, there's a bunch of medications that can lead to some adverse effects. And it's not so much that they may cause direct damage to your nerves, but for example, if you're thinking about statin medications, if someone's taking something for high cholesterol, if they have something like diabetes or they're taking hypertensives, you know that they have hypertension, they're at risk of having some sort of diabetic neuropathy. And that's where you've got sort of the excessive sugar actually directly going in and damaging the nerves. So it's not the medication so much that you're worried about, it's the underlying conditions that you're thinking about. And really, like smoking, alcohol, drug abuse, they all, regardless of whatever system you're thinking about, it will have some sort of effect. And smoking is generally through cancer or arterial diseases. Alcohol and drug abuse are more so because when you're on these sorts of substances, you don't have the clearest mindset, so you may be more at risk of injuries. And then again, in general family history, you're thinking about any autoimmune conditions or genetic conditions that may affect your nervous system. All right, and I'm sorry if I'm going really, really fast with this. It's just to make sure that we get through it in time. With the physical examination, you will have a very, first of all, I'm going to go through a very general approach, regardless of which limb you're working on. So if it's the upper limb or lower limb, because there's a lot of similarities, and then we'll work through specific tests for each of the upper half and the lower half. So really crucial, first, you want to do hand hygiene. I believe you will, I haven't done an osteo physical exam, but you will probably lose marks if you don't go in and wash your hands. So it's very, very important to do that first. Also when you leave the room. Then with looking, there's a couple of things that you really want to take note of, and a really good mnemonic to remember this. I'm a big fan of mnemonics and stories to remember stuff because there's just way too much to remember in medicine. The way that I remember it is P Swift. So we're thinking about P for posture, and then Swift is all the things that are to do with your nerves. So we're thinking about scars that could indicate injury or surgery. Muscle wasting indicates some sort of denervation. So if your muscles are not receiving any of their excitation anymore or any nervous impulse, they're going to start dying or atrophying. I is for involuntary movement. So this can be associated with a lot of conditions, which we won't go into now. Fasciculations, this is interesting. If you look up these videos, they look kind of strange. It's like when you go around all the muscles. So like if you're focusing on the upper limb, you might go to the pectorals and you might try and flick a little bit, very lightly, of course, but you're looking for, if I provide a little bit of stimulation, mechanical stimulation, do they just start abnormally twitching? And that can indicate some sort of pathology. I think this is most apparent in the foot. So that's fasciculations. And then tremors, the way you do this is you get them to outstretch their hands forward, either up or down. I think usually you have them pronating, and you see if they kind of go like this. And the way you can like see this better is you put a piece of paper over their hands, and that way you can really nicely see that the paper is moving if the tremors are not so visible. You should always try and start your observation very early. So as soon as they start walking into the room, you can even look at things like gait, their body mass, whether they have a high body mass index or a low body mass index and things like that. So observation should be starting from the get-go. Then you look at your motor stuff. So we're thinking first tone. Tone is your freedom of movement at your joints when you try and make all the, either the upper limb or the lower limb as floppy as possible. So tell your patient to relax. You will do all the work here. And I'll go into how you test this in the upper limb and lower limb later, so the practical aspects. But if you're grading this, you're thinking first, is it decreased resistance? So am I just able to move all the joints really, really rapidly without the patient being able to actually control it? That's hypotonia, not so clinically relevant. Hypertonia is probably the more important one. So that's too much resistance. And the ways that we can categorize this further is you can think about spasticity. This is when it's velocity dependent. So the faster you move, so if I was to test it at my wrist and I move it slowly, I can sense some resistance. And then I move it faster and suddenly there's more resistance. So that's velocity dependent. And this can generally be due to things like stroke. Rigidity is velocity independent. So I could move it slowly and I could move it fast and it feels sort of the same. Of course, you don't want to move it too fast because that can actually hurt. But that's rigidity, and that's mostly to do with Parkinson's. There are two types: cogwheel, which is intermittent. So that's when it's rigid and then it's not, and then it's rigid and then it's not. Whereas lead pipe is continuous, so it's rigid throughout. And both of those are generally to do with still Parkinson's. Then power is testing your strength of the actual muscles at that joint when you apply external resistance. And the way we grade this is 0 to 5. You can read this in your own time, but you're thinking about 0 being no contraction at all. Then somewhere in the middle, you're thinking about, okay, does this patient require some component of gravity to help them? Are they able to do it like match gravity, or are they able to go match gravity and then go a little bit further? So actually go against my resistance that I'm applying. And that'll give you your sort of intermediate gradings. And then 5 is going to be normal. So that's expected power. Reflexes are really, like, if you get a chance to do this practically, it's a really cool thing to actually do. So I'm not sure if you've seen videos, but all you're doing is you're kind of putting your finger at the distal part of that muscle. So if you think about the biceps, you're putting it at the part where this is where anatomy comes in handy. You're thinking about where does the biceps insert generally. Put your finger over that, and then your tendon hammer hits your finger, not the hammer directly most of the time. And the way you grade that is extremely simple. So you've got from 0 to like down here with pluses. Kind of different to power is that like the maximum is not necessarily good. So 0 is absent, 2 pluses is normal, and then anything past that is a bit too much. And I again encourage you to watch a video on this because it can actually be quite damaging. If you have a reflex, a deep tendon reflex that is coming up as clonus, you'll actually see the patient just like not being able to control like their bicep. If it's just going like this throughout. And that's when you have a really big problem with some of the nerves. If you're not able to, this is a practical thing, if you're not able to get a reflex happening, that could obviously be because of your technique. You're not actually looking at the correct anatomy, or it's because the patient is actually, because they're looking, or they're conscious, like you're telling them to relax, right? But they're looking at it and they're like, what's going to happen? Subconsciously, they're trying to stop the motion or resist the motion. So tell them to either close their eyes or to clench their teeth or to wrap one leg around the other just to get them distracted, whatever the mechanism is, just to distract them from what's happening here. Coordination is looking for some changes in your cerebellum. So we briefly covered the actions of the cerebellum. It's to do with coordination, it's to do with balance, all those things you're trying to test with these sorts of mechanisms. Now, how you grade this, and this is not so much grading, it's just the pathologies you can get. So you can get things like intention tremor, and that's when, like if you're doing a test where you're trying to get them to follow a finger by pointing to it, for some reason that they have some sort of tremor in their hand, and that tremor seems to get worse the closer they get to your target. That's called intention, because they're intending to try and get closer to the target, but they're getting a lot more tremor as they do that. Dysmetria is when they either undershoot or overshoot the target that you're setting. So you say, can you just point, like get your finger closer to my finger, and they seem to go further than that, or they seem to not be able to get there. That's dysmetria. Dysenergia is when you just get total decomposition of their movement. So they try and get closer, and suddenly like the hand just goes flimsy, or they start to get random movements. That's dysenergia. And this really fancy word, dysdiadochonesia, is when they're not able to perform RAMs, or rapid alternating movements. And again, I'll show you what rapid alternating movements look like for both the upper limb and lower limb. If they can't do that, then it's called dysdiadochonesia. Now with sensory, you want to do all of these things. It's a lot to take in, but just think about it systematically. And you might also want to think about the physiological aspects behind it. So what are the spinal tracts that you're actually testing? I'm not going to go into it here, but you may have had a session on it with us in semester 1. So light touch, you're just using cotton wool. You don't want to push too hard because then that's deep touch. So light touch, lightly tap with cotton wool, and you want to go by the dermatomes. So hopefully at this stage you are familiar with the dermatomes. If not, send me a message or send one of us a message, and we can do a brief video on this. It's really important to know what the dermatomes you're testing are, because for light touch, you're using it. For pain, you're also thinking you're having a pinprick, you're going by dermatome. Same with temperature. You're using the back of a tuning fork, which is generally going to be quite cold, to be able to test each dermatome. And you're thinking like which specific nerve roots could be damaged that are causing a lack of sensation in any of these different types of sensation. Remember that, you know, temperature and pain have one sort of spinal tract, whereas light touch and things like that will have a different spinal tract. So really think back to your physiology. Vibration, you want to, and this is actually an exam question that they had, which is a bit strange, right? But they actually specifically want you to know that you have to use a 128 hertz tuning fork. So keep that number in mind. As opposed to temperature though, you want to be, or as opposed to the previous ones, you don't want to be doing it by dermatome. You want to go from distal to proximal. So if you're doing it in the upper limb, you want to start at the DIP joints, or like the interphalangeal joints at the very end of your fingers, and then work your way up. Obviously, if they can feel it at the fingers, you can stop there. But if they don't, then you only have to work your way up, up the arm or up the leg. Proprioception is where you hold the DIP of like a thumb or index finger. Again, lightly hold it by the sides, because you don't want to be using the tactile parts of the fingers. You just want to be thinking about the sides where they don't have much sensation. Hold it lightly and get them to close their eyes, and move it up or move it down, and keep asking them, is it up, is it down, is it up, is it down? If they can tell, then they have some sort of idea of the positioning of their limbs in space, which is proprioception. 2-point discrimination, again, you would have covered this semester. You want to take the ends, the sharp ends of a paperclip, and start small on different parts of the, again, distally, start with distally and then go proximally if you can. Get it really small, and then keep increasing the distance, I think, or the other way around, to be able to figure out what the minimum distance is, at which point they can tell, okay, this is actually two sensations, not just one together. Okay, so that will tell you a bit about the patency or the function of the sensory nerves to the skin. And again, we'll go into this in a bit more detail later for the upper limb and lower limb. Stereognosis is generally just for the upper limb. Kind of makes sense because you're just thinking about, if I get them to close their eyes and put an apple in their hand, can they tell it's an apple just from the sensation of it? You can't do that in the lower limb. Some general tips that I've put, or some general things you want to think about that I put in the comments, are that for most of these, you want to have their eyes closed. I think just to be safe, have their eyes closed for everything, just so that you're able to really make sure that there's no visual component that's occluding or making this test less accurate than it should be. And there's a couple of other things I've added in the comments. So if you want to read that, those are some general principles you want to keep in mind whenever you're doing any sensory sort of stuff. And also the last bit, peripheral nerves, it's technically optional and it's only in upper limb. And I'll go into that in the next section. So now focusing on just upper limb. Okay. First of all, we're doing everything we discussed already. So we're thinking about P-Swift for looking. But another thing we want to think about for the upper limb is this thing called pronated drift. So what you do is you get your patient to have their hands out, as we did with sort of our tremor. This time, get them to have their hands face or palms facing down. And what you're trying to get is, or actually, I think you should probably have the hands facing upwards, because what you're looking for is, if they have their eyes closed, do they have a little bit of pronation happening in one or both of their hands? If that's the case, then you have some sort of problem with the pyramidal tract. Remember the one that's having all those nerves that are going to then give rise to the lower motor neurons. So if there's a problem and they just seem to have some sort of pronation when they don't want to, and again, remember why we get the eyes closed, right? Because if they have their eyes open, they know that their palms are facing up, and so their mind will try and just keep it like that. If you get the eyes too closed, then they don't know what their hands are now, and so you'll get some, because of the lesion, you will get some pronation. The reason why you get more pronation, and thinking back to anatomy that we've covered, is because you generally, if you think about the supinators and pronators, have a go at counting how many muscles do pronation, how many muscles do supination, as well as thinking about the strength of the supinator muscles versus pronators. Generally, you will have less supinator muscles, and they will also be a little bit weaker, which is why when you close your eyes and you have that lesion in the upper motor neurons, then you will get more pronation. Okay, so that's pronated drift. You want to think about tone, and the way that you do this is, again, get them to be floppy, support their elbow, and with your other hand, and I can't really demonstrate this, it's a bit difficult because I need another person, but you will, and it's very difficult to show on camera. You want to look at the wrist, and again, it's very floppy. You just want to move it around, circumduct, whatever you want to do, just to see if there's any resistance. For power, you want to look at all the myotones. Unfortunately, you will need to know a couple of these at least. There are some easy ways to remember them, and if you want me to share these with you, please let me know, and I will send something like a video or some sort of notes that I made about this that make it a little bit easier to remember in exam. But this diagram from, I think it's Morandelli, is a really good summary. So it shows you some of the main nerve roots that are responsible. And this is from your clinical skills workbook. I'm not sure if they may have updated this, but this is the one that we got. And again, it's very, very helpful to remember these myotones. Reflexes. So I can't really talk too much about this because it requires a bit of practical knowledge. So watch a video. We're thinking about biceps reflex. You might have seen that one. Brachioradialis. Think about where that muscle is. Triceps on the back of the upper arm or the posterior aspect. And then finger jerk is probably just don't do it, because finger jerk is very difficult to elicit and it doesn't give you that much information that you don't already have. The main thing practically or theoretically is to think about the nerve roots associated with them. So if my biceps reflex is not working or it's exaggerated, then we're thinking about some pathology with C5, C6, same with brachioradialis and so on. Again, there are some ways to remember this, which make it easy. So if you want to know, let me know. Coordination, think about finger nose test. So you tell them, I have my finger up like this. Tell them to touch their own nose and then touch my finger and then go back and forth, and then say, do it faster. So as a bit of a challenge. And if they can't do it, obviously there's some problem with their coordination. With the RAM, so rapid alternating movements, the way you get them to do that is you hold your palm out, or they can have their own palm, and get them to take their other hand and just go like this. I'm not sure if my blurring is making it. Yeah, you can probably see it. So you go up, down, supinate, pronate, like that. faster, slower, and see if there's any issues with that. So you might actually see they do this, and then suddenly you tell them to like stop, and they just can't stop, right? There's like some sort of dysynergia happening. So all those problems can arise. And then ballistic tracking, again, have your index finger up and move it around. So you as like a sort of ballistic sort of target, and then tell them to keep pointing at it or keep trying to aim for it. And you might see some pathology there. But for the most part, with most of the patients you'll see, everything here will be normal. 2-point discrimination, these are numbers that you unfortunately may have to remember because it can come up in your exam in multiple choice. In the fingertips, it's generally the most sensitive region. So it's about 6 millimeters minimum distance before they realize, okay, this is 2 points of sensation rather than 1. And at the hand, it's a lot larger. So if you think about, usually the back of the hand is where you test it. That's about 30 millimeters, so 3 centimeters, quite a lot. And stereognosis, just put stuff in their hands and see if they can tell. So whatever you have on your desk, just try and put it in the palm and see if they can identify with their eyes closed. Dermatomes, again, like compared to myotomes, dermatomes can be really simple. They have an embryological basis if you've talked about that in anatomy. But to remember them, it's really easy because it just goes around your around like C4, C5, C6. Let me just get my highlighter. The way it works, yeah. So you got C4 going around C5, C6. The easy way to remember is that C7 is in the middle, and it's also the middle of the brachial plexus. So C7 is in the middle finger, which is also the middle of the brachial plexus, and everything goes around it. So then C7, C8, T1, T2, and so on. And then this is just the back, but really like you just be testing it from the front most of the time. And remember, these are associated with light touch, you got pain, and you got temperature. Everything else is usually from distal to proximal. All right, and finally, is a bit of a optional thing. You can look at each of the nerves that are going more distally. So musculoskeletal and axillary, we're not really going to focus on those too much because they kind of end a little bit earlier. For radial nerve and each of these nerves, you want to think about the motor and sensory components. So for the radial nerve motor, you want to think about things like wrist drop. Remember why? Because radial nerve is usually doing all the extensors at the posterior aspect. So if they don't work, you're going to have your wrist just being like dripping down or like this. And sensory, of course, it has a really wide distribution, but clinically it's really simple just to look at the anatomical snuff box region in the hand or the back of the hand, because that is the easiest place to test for radial nerve distribution. Median nerve, you want to think about two ways. Two ways you want to look at it is at the wrist and as well as at the elbow, because you can have pathology in either spot and it'll actually result in different presentations. So if you have a pathology at the wrist, you will have a loss of your thumb abduction, because remember, some of the intrinsic muscles, especially of the thenar eminence, are going to be innervated by the median branches of the median nerve. So the way you do that is you hold a pen up, and maybe I have a pen. Yeah, you have a pen, and you hold it above the hand like this, and you tell them, can you please abduct, or obviously you don't say abduct, but can you please try and touch your thumb to the pen? And so they go up. That's abduction. They can do that, and you can maybe apply a bit of resistance against that, then it's okay. There's no pathology at the wrist. And if there is, then you might want to test for pathology at the elbow, because they can overlap. So the way you do elbow, and I have a picture of this in the next slide, is you use the Ochsner clasp. So basically it's just doing this, or like, yes, you just sort of get them to do this. What you'll find is that they might not be able to flex their index finger of either one side or both sides, depending on where the pathology is. And I really encourage you to think why this is the case. So what is the median nerve innervating that is causing this pathology within the intrinsic muscles of the hand? And then you've got your sensory innervation. This is just revision. You've got your lateral 3.5 fingers. With the ulnar nerve, you can passively just see, do they have an ulnar claw, which we covered in anatomy. Froment's sign is something I'll show in the next slide, where the APL, so adductor pollicis longus, which is innervated by the ulnar nerve, is weakened because there's no innervation. What consequently happens is that the FPL, flexor pollicis longus, which if you can, as a challenge, type in the chat if you know what the nerve that innervates that is, will try and compensate. So it's not the ulnar nerve, it's another nerve that will compensate for that. And of course, sensory will be the medial 1.5 fingers. This is Ochsner clasp. So you just have them clasping together. The index finger will not be able to point out. And you might remember that it's not just the index finger, right? It's a couple of other fingers that are innervated with the median nerve. But because the other ones are sort of tightly packed in, they'll be able to flex relatively okay because you've got more supports and you've got more clamping happening. But at the top, that index finger doesn't have that much to keep it there. So it'll just like point out. And so that's a positive Ochsner clasp. And then Froment sign, you're trying to just put a piece of paper like this and telling them, can you hold it as tight as possible while I try to pull it out? What you'll notice is that because that APL is not working so well, so it's not adducting properly, the FPL will try and compensate and keep it there. But the FPL has an additional sort of part, which is that it'll try and flex at the thumb. So it's going to kind of tent up like that. Okay. And then lower limb is a bit easier. The looking part, there's a bit more to do. So with muscles, you want to look for proximal strength. So get them to have their hands across like this. And the reason why we do that, so we get them to do this, like basically hug themselves and then rise up from the chair. This is the reason why we do this, is because if we get them to just stand up normally, they can use the weight or the momentum of their arms to push themselves forward, which is not what we want. We want to test whether the proximal muscles in the hip are working properly to allow them to stand up. It's a very simple one. The second one is Trendelenburg test. This is something you will come across in, I think you should have come across probably in anatomy, probably in your tutorials or something like that, where you're looking at the strength of your hip abductors and specifically your contralateral hip abductors. So we're thinking about things like gluteus medius and gluteus minimus mostly. What you do is you get them to stand up and get them to stand on only one foot. What will happen is you might see a bit of a drop on one side. So if you get a drop on, say, for example, this patient's left-hand side, visualize the anatomy. And what's happening is that, remember the gluteus medius and stuff, they're not just for adduction of the hip. They also stabilize the hip when you're sort of running or walking. So if it's not pulling down properly, it's not going to be able to stabilize and make the hip horizontal again. So if that's weak, it's an indication it's gonna cause a positive Trendelenburg test. Just really, like, it's super important to drill into your mind that this is a contralateral pathology. So if you see something on the left-hand side, it's not the left-hand side muscles that are not working, it's the right-hand side ones. Now I know you probably guys have your session happening now, but for anyone who's still watching or for the people on YouTube, I'll go into the rest of the stuff in detail. So we finished muscles. Then we go on to gait, and we're looking at the ways that this person is walking. So you can just look at their gait normally as they walk into the room, but also you can test certain nerve roots in terms of the specific ways that you can walk. So with the S1 nerve root, you can ask them to walk on their tiptoes like this. And when you get down to the lower leg and to the foot, I want you to think about what muscles are innervated by the S1 root, and therefore why is it useful that we get them to walk on their tippy toes. Okay, then we walk on their heels. So the opposite of this, walk on your heels. And again, think about the anatomical basis when you get to this in 1 or 2 weeks time. This is the L4, L5 root. And finally, this is more so for balance. We're asking them to do a tandem walk. So if you ever walk across a tightrope, we're doing a tandem walk where we're going from heel to toe. That's testing your cerebellar function. Now, balance is very straightforward. You've got Romberg and you've got pull test. You want to be really careful with these though, because you don't want your patient to like fall over or anything. So be like, as this doctor is doing here, make sure you are being cautious, that you can prepare for just in case your patient falls over. Romberg test is where you get them to close their eyes and just standing there, are they able to keep their balance? If not, then they may have some sort of central nervous problem or extrapyramidal problem that's causing them to not understand, first of all, where they're positioned and whether they're losing balance or not. The pull test is more active. So if Romberg test is fine, you do a pull test where you try and sharply pull the patient from the back, obviously warning them, and see if they're able to correct themselves. If they are, then it's fine. If they're not, then again, there's a pathology in the cerebellar region. Now, tone, like we did in the wrist, you want to stabilize. So you stabilize the elbow and then do it at the wrist. Here, you want to stabilize more proximally. So like what this doctor is doing here, stabilize the lower leg. And actually, this is more for clonus. You can do it at the joint here, but generally for clinical skills, you will do it at the knee joint. So stabilize the thigh and then ask, like you use your hand to sort of flex and extend the knee at different speeds. And you want to, again, look for all those signs of Parkinson's, you've got the rigidity and the spasticity. With the clonus, there are two specific ones you want to test for. So ankle clonus is the one shown in the image, where you're stabilizing the lower leg, and you're just going to keep on sharply dorsiflexing the foot. So dorsiflexing, you'll learn this later, is just like getting the top of the foot to come towards you or come towards the patient. And you want to try and get the knee to be slightly bent, their thigh to be slightly externally rotated. And if you notice that their ankle or their foot just keeps going like this, that's a positive clonus test. And the patella, so the patella is the bone that's anterior to your knee joint. You get the patient to fully extend their knee, and between your thumb and your index, you want to just sharply pull down the patella. Obviously, there's not going to be a lot of give, but try as best as you can to pull it down. And if you do notice like just some sort of abnormal movements at the knee, then that's a positive patella clonus. Again, all these are pathologies linked to your central nervous system. And then power, again, think about all your myotomes and think about the specific nerve roots that you're testing. So if you notice that the nerve root that's going to a specific motion is also a nerve root that's being affected with some of the reflexes you're testing, then that gives stronger evidence that perhaps L2 is affected. And that will be a good way to sort of tailor your investigations after that. So think about all these, and this is a nice diagram again from Tally O'Connor, I think. Reflexes, look at your knee reflex. You want to think about your ankle reflex and your plantar reflex. Search these up on a video because it's very difficult to show visually right now. But they all have their associated nerve roots and they kind of go down. So L3, L4, skip L5, you've got S1, S2, and then you've got L5, S1, S2. Babinski reflex is a really cool one. So you get a little pen or something, or the back of your tendon hammer, and you want to kind of drag it up through their foot. And normally what should happen is that their fingers or their toes should be able to curl downwards because of that. It's sort of an instinctual response. But if you have a positive Babinski sign, you will have it going the opposite direction. And it's actually a remnant of sort of development, and it shouldn't be there. So if that's the case, then you have, again, some sort of pathology. Okay, really quickly, you've got coordination, similar to the ones we did with the upper limb. You've got heel to shin, so you get them to, look, for example, in this patient, you've got your right lower limb. You get that heel, and you try and run it up and down the opposite side, so the left-hand side, and then swap sides, just to make sure that they're able to coordinate that properly. With the RAM, so in the upper limb, it was like this. With the lower limb, you want them to tap the sole of their foot against your hand repeatedly. And again, you're looking for something just like they're not being able to control that movement, or they just can't do it. And the toe finger test is very straightforward. It's kind of like the nose or like pointing to my index finger, except they're doing it with their big toe. And it's sort of demonstrated here. Finally, sensory. So you've got your 2-point discrimination. Again, use the paperclip. The sole is not great for 2-point discrimination. So it's 2 centimeters, 20 millimeters that you'll have minimum mostly. And if it's more than that, then again, you've got a pathology. With the big toe, it's not as great as your fingers. And obviously evolutionarily, that makes sense. You're using your fingers more for sensing things. So with the big toe, it's about 12 millimeters. And remember, with all your dermatome tests, light touch, pain sensation, temperature, you want to alternate between your left and your right to compare. Also, one thing I forgot to mention, but it's in the speaker notes, is for dermatomes, you want to always compare it to a set standard. And the way you do that is by first testing it on the sternum. That's just the way that you usually do it. And then you go down to the lower limb or upper limb. So if you're thinking about pain sensation and using the prick, first do it on the sternum and say, can you feel that? They're like, okay. Then do it on the lower limb or upper limb and say, does that feel the same as it did when I did it on your chest? And then they'll be like, okay, yes. Or they'll say, no, it's a bit softer, or I can't feel it as much. And that is it. There's no peripheral nerves that you really need to look at in the lower limb. Again, I know I've gone through really fast. So please go over the slides, go over each of them. Oh, I just looked back and there's not actually that many people left. That makes sense. Yeah, look, if you're looking at this on YouTube, please go over the slides, go over them one by one, and try and work through each test systematically so that you're able to actually perform it when it comes to exam time. Awesome, that's it. Thanks, everyone.
Easy peasy.
Thanks, everyone.
Thank you, everyone.